My name is Laura Quinn. I'm the manager of respiratory care. My pediatric experience, my first hospital, I was at in North Carolina. We were a level 1 trauma center for peds. We had a level 4 NICU, which are a bit more rare because you do all the surgeries and everything there. So I only worked neo peds for my first 7 years. After there, I went to all children's and did more peds. And then I went to the big people world. So.
I'm Michelle Gibson. I've been at SMH my entire respiratory career. I started NICU, and that's primarily my specialty area is NICU. I handle peds when they come in from you guys, and we get them usually, or if they're coming in and they're in distress, and work from there. So I do a lot of NICU, NRP, teach, PALS, teach, things like that. So, and we're just going to go over some respiratory things today.
Yep. Right.
So with newborns, they have 3 primary questions that they like to ask. And the reason we like to ask these questions, I'm getting out of the video space, sorry, is because of how we're going to treat them from there. So a lot of the times when we ask these 3 questions and we're trying to figure it out, there's different reasons. So the first question we want to ask is, what's gestational age? The reason for that is because when we get the baby, it's different equipment we're going to use. So it's like we want to have the settings in, we're going to have different blades, everything like that, so everything we can get it on them. Also, our NICU team comes straight down to help us anytime you bring a baby. So a neonatologist is going to come in, NICU therapist, and so forth. The next question that you're going to ask is prenatal care. A lot of the times, there's not going to be prenatal care, and we get those babies, and they're a lot sicker because they didn't get all the medications they needed or checkups, or there's a lot of complications with those babies that we're not expecting, or the mom didn't know that they were pregnant type of situation, so they might have been doing things they should not have been doing during those times, and those babies will have respiratory or withdrawal or any other issues that go along with that. So we like to start treating that right away. And then the last one, or not the last one, but amniotic fluid. The reason for that is because if it comes out and they have meconium babies, we're going to treat them a little bit different. We're going to more aggressively suction them. We're going to be making sure that we have intubation supplies ready, because you think that those babies are fine, but they just don't have the reserve that they should have already. And then the other thing that goes that is if it smells. Some of those babies come out, who's been to a delivery and the baby comes out and you're like, oh, it's just like reeks because they've been ruptured or whatever the issues are, and the infection's already brewing in there for that baby. So we're just going to get antibiotics on board right away, and it's just little things like that could help us. You might clean the baby off, but by the time we get us, it doesn't smell anymore. You know what I mean? So just any little tidbits like that really, really help us with that, with those treatments.
And also to start, then the team will start antibiotics right away on the baby rather than waiting. So.
Yeah.
The other thing is knowing where they are in their transition. So depending on the age of the baby, which was why one of those questions is there, there's different things obviously that are going to happen in the whole cascade of them growing before they're born. And then when they are born, there's massive changes in circulation, respiration, metabolism, because they're not doing any of that really on their own. Well, circulation, I guess, somewhat. So just to give you an idea, there's no tests on this, but I thought it was really interesting. So you're looking at like if the mother, so this is the blood coming from the mother going through the vein is already at 70 to 80% oxygen enriched, right? And then once it gets to the baby, like their heart and their lungs, it's only at 55 to 65%. So that's where they're starting from, right at birth. And so that transition, once they get oxygen, everything changes. It changes their circulation. There's different shunts and things that close off. And so knowing when the baby was born and everything is important for that reason, because, like I said, that first second, hopefully, if it's a regular birth and we're getting all the fluid out of their lungs, the baby has to take that first breath and start to build, we call it FRC, functional residual capacity, and that's so that their lungs aren't going to collapse. So those first few breaths, and if there's still a lot of fluid in there, there's less room for that. But within those first few breaths, the oxygen content is going to change everything pretty drastically from that. And this is one of our target numbers for for saturations after birth. So that first minute, there's not really a whole lot of difference here. And so keeping that in mind, I know you guys, probably the fastest you guys are going to get to a baby that's already born on oxygen, and we're really only at like 85 to 95% by 10 minutes, and that's okay. Again, back to the gestational age, if we're looking at a 32-week or younger, those numbers are changing. So, sorry, that was the other thing, was the blood pressure. So, as soon as the cord is cut, baby has their own blood pressure. And again, looking at infection, this is a positive thing. Looking at infection, looking at circulation. That's why those saturations are a big deal to us after birth. Going to be right there. Yes. Yay.
So newborn intervention, we always have the pulse checks. A lot of the times, where are we going to put the pulse ox on a newborn when they come out? Does anybody know? Right.
Where?
Yeah.
On the foot.
On newborns, we do the right arm.
Oh.
Okay. And if you had to check for a pulse, where would you check that? Brachial. And the brachial, remember, on a baby is going to be a lot higher than you are going to think it is. Like, we look at an adult's brachial and we're filling down here. So sometimes people who don't deal with babies a lot, they'll go for it, and you're not going to really feel it down here. You're going to want to go higher on it than you would for an adult. Cyanosis within the first 5 minutes is really normal. This is their transitioning times. When we have a baby in the hospital, and you guys have them too, it's a little bit different, but when we have them in the hospital, we're just sitting there in transition, and the parents are going to be freaking out the whole time, as we know. But we are doing our things. We're stimulating them. We're drying them off. We're kind of doing our things that we need to do for them to transition. As she was saying before about the times, you don't really have to start worrying until it's about 10 minutes and you're still having cyanosis, work of breathing, or they're apneic. Apnea, warmth is huge, especially the really, really, really small babies. Sometimes we have like 28-week babies that come out, and the first thing we're doing is putting them in a little bag to keep all of their warmth in there. We're not even drying them off or anything like that. We're putting them straight in that little bag to keep them warm. Pneumothorax is huge. So we figured out in our facility that we would have any baby, we would come out and they were desatting or they were doing anything, we would just give them CPAP, right? We give them a little PEEP, a little oxygen if they needed it, and then go on there. We realized we were getting a lot of pneumothoraxes from that in deliveries. So our new practice within SMH is to do, what we do is if they're not working to breathe, no nasal flaring, we'll go over all the workings with examples later, and they are full-term babies, we just give them blow-by. So we'll review that as well. So you can just give them blow-by, and then if they have any work of breathing, then that's when we go to the CPAP, and we realized that helped a lot with the pneumothoraxis, because when you get that, then you get all those other problems, right? Heart rate, and they're desatting, and everything else goes with it. Hypoglycemia, we are big on those small babies too, as well as they're burning through that really quick, right through that sugar. They're getting really stressed, they're coming out, and obviously you wouldn't be feeding them, but just so you know, for us, if it's for some reason the baby was there for a very long time or something like that before it got to you, when they burn through that, then they have issues with the sugar, and then we're making sure they get fed right away. So any information you have towards that's like great as well. So. Blow-by, we only really use 100% is if like time to do resuscitation at that point. We try to really keep the oxygen low for the majority of all of the transition. And then meconium. So meconium is a big thing that gives us a lot of respiratory issues, and it can go from nothing and barely any problems to babies intubated and going to all children's and everything like that. I personally had a friend recently who had a baby at our hospital, and she had a little bit of meconium, didn't think it was a big thing. Baby goes up to the NICU and is in the NICU for 24 hours, and she's freaking out. And the baby's completely fine now, but it's just that transition. You get all that meconium in the lungs, and you can't do all your diffusion and so forth. So we got to clean that out with suctioning and stuff like that. So if you can get the suctioning done too, that's helpful as well. You have a meconium story too.
Yes.
We like stories.
When we were asked to come and speak with you all, one of the things that we talked about was the birthing centers, and I was on the receiving end. I was working at Lakewood Ranch, and it was like 6 a.m. or something, and baby came in from a birthing center, and we were asking those normal questions and everything, could not figure out why this baby was not transitioning, and it appeared that every time we were turning the oxygen up, the baby would the baby would desat and then opposite, which can also be an indicator of congenital heart defects. So because I had this other previous, long peds experience, that's what was going through my mind. But we had asked, was there meconium? And they said, no, everything was fine, because they're trying to maybe protect what they've done at the birthing center. And so so it really changed how we approached this kid, because we said, no, everything, there was no meconium, fluid was clear. And so that's why we went the totally different direction of congenital heart. So take all of that information with a grain of salt, of course. Ask the questions, ask but verify kind of thing. So so just know that that's one of the things that can come of that, is that they're shunting.
Pediatric assessment, it's different in adults. I started in NICU land, so I went to NICU land and lived in that land, and then they're like, just go to adults, it's the same. It's not the same. Nothing's the same, right? So we all know that. The assessment, the respiratory rate's going to be a lot higher, as we all know, so that's not a worry for us if they're breathing really fast. The accessory muscle usage, the way that their accessory muscles are used is going to be different, because they don't have so much of the intercostals and so forth, and the breathing pattern. And they're not just little adults either. It's completely different how you would care for them. And she does the little mask thing.
Everybody wearing the little dinosaur
She's
face.
funny, I'm not funny.
And with the accessory muscles, because of the shape of a kid's rib cage compared to ours, their accessory muscles go in a different pattern than adults. So adults with CHF, we tend to see suprasternal, maybe supraclavicular before we're going to start to see anything here. Partially because they're fatter usually too, but we're going to see that as the first part of things, just of this kind of tugging in this area. With kids, first is intercostals. And so don't be afraid to, tell them, oh, let me look at your belly. Most kids, once they're, until they're a certain age, are going to be like, all right, here you go. And looking at the intercostals, because if you start seeing the suprasternal and definitely supraclavicular are a much later sign of respiratory distress for those kids. So knowing that there's the difference of those also.
So here's some examples we have, because I know I'm super visual, I want to see things, and I'm sure you've all seen these before, but some of them may have been a little bit. This is the grunting baby. This does a lot, like the newborns when they freshly come out, this is one of their early signs of work of breathing. And you can hear it. Oh, I kind of talked over it, sorry. I talked over it. Go back and then back. Back.
Is the mouse
Oh yeah.
functified?
Left arrow.
Yeah, I just left arrow it.
Can't see that, but okay. Done. Okay. Oh, there you go.
Parents always think it's cute. They're crying. You're like, that's not cute.
Right. If it's rhythmic with the breathing, it's not just that.
Yeah. And the other one, seesaw breathing.
Get ready first.
Think of this with asthma, like late stage asthma. They just can't even have enough expiratory phase. They're pulling in. Watch real early on this one.
See those little nasal flares? They're trying to open up their airway, make their airway bigger. So how they do that is their nasals flare out.
And if you had this kid's shirt closed, you might not think anything of it, except if you saw the nasal flaring. So yes, he had his intercostals were showing some work, but if you didn't see that, you without actually looking for the nasal flaring, you might think the kid's perfectly fine.
Head bob is another one. I had a cousin that had a head bobbing incident, and she thought that the baby had hiccups. You have the hiccups, right? Okay. So.
And even though they're asleep, might think, oh, cute.
Yeah. So asthma is one of the things that we mostly get where you have a lot of children who have asthma come in, and you guys are going to have them as well, bring them in with their really bad cases. good thing to know is most recent treatment, but mom can say, oh yeah, they just took one, but just took one could have been 2 hours ago with everything else that's going on. How effectively they got the treatment, if they had a spacer on their inhaler. They could have just taken it. We used to think it was a good myth that like if a baby was crying while you did like a neb treatment on it, they got it better. It's better, right? Because they're, no, all it does is to the back of their throat and it doesn't go anywhere else. So even for us, we're trying to have like the parents give it and stuff like that for us, but I know that's harder for you. We hit them really, really hard too with medications in our hospital. The reason for that is because they metabolize it so quickly, and we're not going to worry about heart rates with kids as much as we're going to worry about with adults, giving them like different types of medications and watching them with that. Laura found this great fact of how many pediatrics have gone in SVT from albuterol. In a recent study, it was 3.9 in 10,000. Like, we do not have deaths come from kids from giving too much albuterol. I know, it goes on Reddit.
Just to piggyback on that, so the most recent treatment, like Michelle said, oh, I just gave them one, because parents are sent home with their kids and they're told to only give every 4 hours at the most frequent. And then if they're starting to see distress, okay, they might go to every 3 if they're going to bend the rules, but they're really not, they're told not to. And so they might say, I just got it, but it might not be true. Particularly if the parent said, no, like we just stopped it, you still want to give another one because you're going to put them on a heart monitor right away and you know where they're going, right? So the SVT is the rhythm that comes from too much albuterol. I teach PALS, and when I teach PALS with respiratory therapists in the room, I always ask, like, who of respiratory therapists has ever seen SVT in a kid from giving too much albuterol? And in several years of teaching PALS, not a single hand has gone up. So asthmatic kids will die from the breathing issues way before they're going to die from the heart rate issues. And so also, you know, they hit them hard before the inflammation sets in. If kids are struggling for longer time, like all the like cytokine release and everything makes the inflammation have more time to set in. So if you can hit them hard and clear their airways faster, then we have an easier time on the back end, so that the exacerbation isn't as long. Oh, and we're number 1 because it's the most common chronic pediatric disease.
Upper airway obstruction, the main ones that you're going to have are foreign body obstruction, the grape, the blueberry, the toy, the whatever that they found around the house on the floor. So you're going to do your effects to get rid of that. There's 2 other things, so croup and epiglottis. I always want to say that wrong. Croup's going to give you that barking cough and the stridor. Oh, sorry. And it's associated with having upper respiratory infection. So if recently they had an infection, you're going to hear that kind of sets off a red flag for you. And we give race epi for stridor. So a lot of times I'll say to people, you know, what do we nebulize race epi for? And everybody's like, stridor, right? So we all know what that stridor sound is right in their neckway area. Epiglottitis is going to be a high fever. This is going to be where you never want to go inside the mouth, right? Because if you do, their airways will just close up because it's inflamed so much already and it's just going to continue to inflame. There's a hot potato voice that goes along with it, and they tripod, a lot more tripoding. So you kind of see some of those like asthma things in there with it as well, where you're like, they're tripoding, and drooling, which can also be foreign body. So it's kind of hard sometimes to differentiate. Thank you. Foreign body from your epiglottitis. But foreign body, you're going to want to try to get out. Epiglottitis, you're not going to want to touch the airway.
Epiglottitis is pretty rare now because of the vaccines, but people aren't getting vaccinated as much.
Right. It's
caused by Haemophilus influenza. And so we don't see it in kids that much. We see it actually more in adults now. But there's, this vaccine hesitancy, we're going to see it more, I think, coming on.
And they're going to be so swollen, and the drooling is a good indicator, because hopefully a 5-year-old is kind of over putting things in its mouth and getting things caught. But a 5-year-old shouldn't be really drooling either. So that's kind of, hopefully cluing you in on which direction you're going to go there.
And then just one comment on croup, sorry to interrupt. We don't carry racemic epinephrine. Typically croup won't be like too destabilizing. Maybe you guys, correct me if I'm wrong, it's not like, they don't get super sick from croup. They need to be managed, but they don't get super sick. But if you have a super sick croupy baby, you just nebulize epinephrine too, so which we obviously have. But you can just call for
that. Because that one sounds so funny, I think that one sounds so funny. So you get a lot of parents that come to the ER early with it because because of the crazy noise. It's the seal cough, right? And so the interesting thing is they were giving out racemic epinephrine to everybody for a while, but they were finding like, okay, it's a little bit much. You don't need to necessarily have the side effects of the increased heart rate with it. So most parents are going to already come straight to the ER before you guys would see them. So if you do see them, like you said, if they're in that bad a shape by then, go for it. Okay. Here's the video.
This is the desktop created over this video.
It's a tough one to hear, but it's the most, it's that nasal, because everything is all swollen in their entire airway.
So allergic reactions.
It's my best slide.
I laugh every time I see it. So allergic reactions, you're going to have epi or albuterol. With allergic reactions or any reaction type thing in the airway, you're always just going to want to remember you're going to need a smaller ET tube. So, I mean, adults, kids, everything's the same way. And sometimes they'll start choking on their drooling and so forth like that. Near drowning, this is like the worst cases I feel like that we always get. Like for everybody, it's the hardest on the entire team for everybody. Lots of suctioning with them. We've learned too to increase the PEEP. So if we increase the PEEP a little bit, it helps with just like CHF or anything like that, that increased pressure helps get rid of things. Gastric distension, so big thing with babies as well as with kids, when we're bagging them or anything, all the air is going into their belly, so their diaphragm, they're getting smaller and smaller and smaller space. So we like to make sure that you get all of that out. There's a higher increase for the vomiting, which we are aware, and then they have aspiration issues, and we have the surfactant washout. So once they get that surfactant washout, it's really hard to get them oxygenating again. There's initial versus secondary in pediatrics, which we know like the kid just had a swimming class yesterday and they choked on a little bit of water and now they are coming in and they're having other issues, and that's your secondary drowning, and it's just as serious as having the other issues. And we always have this big debate within our department that's saltwater versus freshwater versus pool, like which one's the worst? So who thinks that saltwater is the worst on lung damage? Who thinks freshwater is the worst? Lung damage.
So everyone thinks pool?
I think they're equally because there's chemicals.
So actually, it's the studies that we found were that fresh water is the worst damaging on the pool because the osmotic pressure of where it goes through with it and the bacteria and everything like that. Pool is just, we see it more, especially in Florida. Like at home, especially even, like my kids are out by the pool and I don't think like as much, like you're like, oh, I'm gonna go inside and get a water real quick or something like that. You're at the lake, which we don't really have those around here, or the beach, your eyes are on them all the time, right? So there's just more incidents with pools, so that's why it's more detrimental death-wise, but lung damage-wise, it's saltwater, or freshwater, which I always thought was interesting. We had the big debate too, and everybody goes like different ways with it. So as we know too, I just put like a little statistic of increased immersion time, increases the possibility of death, just so you see it. And we all know that, or severe neurological impairment, I can't talk today. We all know, like I always say, like I'm always in my head, 3 minutes, it takes 3 minutes and it all happens. So just to kind of get like a visual.
The initial versus secondary, I was the skeptic. I thought I was like, what are they talking about? The secondary drowning, but it really is something. So again, listening to the parents, the kid seems to be in some sort of distress, and they choked on water last 2 days ago. That could really be the thing that's affecting them then, and it's good for us to know. We actually started nebulizing different medications. Pharmacy starting this thing, so for like. Chlorine inhalation, we can give different medications now nebulized once they come to the ER, so to help with the damage there. So so all that kind of information is really good for us to know. All right, chronic kids. Just a couple things on this. For kids with trachs, if you guys can grab any emergency equipment, spare trachs or anything to bring with you, depending on how much time you have, is really helpful for us at SMH in particular, because often chronic kids either have really funky airways and really specialized trachs, or we just don't have as many of the backups on pediatrics. Congenital heart defects, just a reminder to not fluid overload those kids, because that brings us into the picture even faster if they're fluid overloaded. And then Down syndrome, this was a fascinating statistic, but so by age 5, 79% of Down syndrome children have either current symptomatic upper airway obstruction, so they already snore and have airway stenosis issues. So the pictures here, A is how bad their airway stenosis should be. D is what it should look like when you're going to intubate. So that's a lot scarier, I think. If you look at the size of the vocal cords, in comparison in the picture, it really shows you what the difference is there. So like all the grayish looking color there should really be black, black looking into it. So, and that's just showing the process of doing the airway dilation. So between the giant tongue and the airway stenosis, know that if you have a Down syndrome patient that you need to intubate, probably like a full size smaller for most of those kids. Like not just a half, but.
So we use Mr. SOPA a lot, and I'm sure you guys probably know something like this or have something similar, but it's always good to refresh it. Even when I teach NRP, everybody's like, yes, what are those things again? So that's just for when we're bagging on newborns, like part of our initial steps through a delivery. So it's called Mr. SOPA, and so it's like a fun, easy thing to remember if you're having any problems getting chest rise or anything, because their faces are a lot different, and that's the last ones we want to be bagging anyways, right? So Mr. SOPA, we do the M and the R together, so it's mask reposition. So you reposition the mask and make sure everything's good. You got a good C and E on it. The next one is suction and open airways. So you're gonna suction the mouth, and when you're doing that, especially if it's a really, 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 really small baby, the mouth's super, super small. So you think that the airway is good and open. They like to take their tongues too and get stuck to the roof of their mouth. So when you're suctioning in there, you might be popping that tongue down. So that's very helpful as well, because then you can't get your pressure. If you're still having problems with chest rise, then that's when you can increase your pressure a little bit, and then finally you'd have an alternate airway. So if you're not getting chest rise, or things are kind of like you're getting barely any chest rise, those are the steps to do to kind of help that. So Mr. SOPA, so just our fun little thing. It's NRP, but.
Yes. I saw this kid. If my immediate thing would be, oh my gosh, life gives you lemons. This is not a kid that I would want to intubate, so get Michelle. Done it a heck of a lot more recently.
So intubation for babies, like I was saying, I started with babies, so like I could give them this little precise thing, and then I went to adult and I was like, whoa, this is a lot easier. Just throw that thing down the throat, easy peasy thing, right? So we're gonna have, you're gonna use a Miller blade. It's all about positioning, especially if you have one of those like really chunky diabetic babies. You can put a little roll under them so they can roll a little bit. Their heads too, if they're apneic, are super floppy, just like it, but I mean, it's like a lot floppier than an adult is gonna be. So that can crush down your airway. They're gonna have big slobbery tongues compared to adult. And it's really hard to get in there, so you're gonna use your blade and kind of just sweep it out of the way.
And they're not dried out like the old people that haven't eaten in 3 days.
They are wet, like it's just just secretions. Even if it's a meconium on top of that, it's gonna be tons of really dark secretions. They're gonna have a smaller larynx, and it's gonna be pink and anterior. I kind of did some pictures so you could see as well, like the comparison of what you're probably used to seeing with an adult compared to like how an infant's gonna be. It's like you get this nice, beautiful thing, and then you get a baby and you're like, oh. Especially if it's a baby that's been down, it's gonna be stiffer, and you're not gonna really see any cords at all with that, okay? At the top is an infant and a toddler and an adult, and you can kind of see how it can change, but it's very hard sometimes to see the cords that you need to see to make sure it goes in. What happens a lot is people put the blade in and it goes way too far, and that's how they intubate into the esophagus on a baby, because like one, it's a little bit different and nervous thing, and the sizing can change a little bit. Like adults, you're always gonna pretty much use the same size blades, right? So when they go in, just pull back slowly. Every time I go with a new person to intubate, they're like, I can't see it. I'm like, slowly pull back, and then it'll just pop into view really easy for you. Another thing is crank pressure, but you just gotta watch to make sure you don't do too much. So a lot of time in intubations, like even our NICU nurses will do crank pressure. If you push too hard, then you just collapse everything and they're not gonna see anything. But they're so interior compared to the adults that we're used to intubating that we're thinking we're gonna see it. Like, why aren't we seeing it yet? And that's why. Resistance, if you hit any resistance at all, and I've had this happen a lot, like you'll see the line, you have the lines on the tubes. I have some tubes, oh, that one's in the thing. We'll talk about it. Okay. So you see those lines and you're going to put it in and you can't get it in or you're hitting resistance because depth, like a thing we do for the depth is 6 plus their weight, like in kilograms. So if you're not getting it in far enough and there's resistant, you got to get another tube and try a smaller one. They might have an obstruction in there or something like that. Or even I've had it happen before, like communication may be off on the gestation or anything else of the baby. So we might think that we need a bigger tube than we actually need. No teeth. This is one thing I do love about babies because they can't bite you. Like, what do we say to everything about adults? Never put your fingers in their mouth, right? Never, ever, ever, ever put your fingers in your mouth. A baby, though, they're so slippery, and like really small babies, like half a centimeter is extubated. So when we're taping them and stuff like that, I hold the tube at the roof of their mouth, like inside their mouth. And like, I really get in there because I don't want to extubate because babies too, when you're intubating them, they bleed a lot more and they swallow a lot more. So that second time putting that blade in, you're not going to see anything. So you just want to you don't want to have to do that if you need to. Because I've had a lot of deliveries where we went in one time and then it's just gushing blood after that because they're so sensitive. And then you have your dope of like repositioning and so forth to help as well. You want to add anything? No. Okay. So I put little heads on everybody's desk with tape. We do a Y thing, which this is how we do it at SMH, but you can always do something different. Another story I had, which this wasn't me, but somebody else happened, they put the tape on in a transport, because we have the transport team as well, and they went to cut the end of it, and they slit the baby's cheek. So it's like scissors are really, really big. Nobody wants that, right? Starting off.
Hang out.
So even if I have to use, because we used scissors to cut our tubes once we put them onto the vent, I always like cover the face. So if you ever have to use scissors in any ways, just make sure you cover it, and I always keep them out of the way. We do a Y crisscross, so I got heads here if you guys want to practice. And I kind of did the first one. I bought this tape we have because the other tape does not work good on these mannequins, but this is what the tape we use actually in the NICU. So we do a Y crisscross, and this one, you take the tape, and I cut it for you guys already too. We do like pre-pack, like we kind of do it in advance, but you can do it in a last second thing. And we take the back off the tape and put it wide in the corner of the mouth. So you have the tube you hold in the roof of the mouth in the corner of the mouth. And we put a Y right here on the edge and just bring this over as far as we can. And then you wrap it around, okay? You can take it off and do it. I put little tubes, you don't have to intubate, you can just like throw the tube in the mouth.
Because some of those heads can't be intubated.
Yes, some of them can't be intubated and some of them can. So you go ahead and you wrap it around. We always tab the end too. You're gonna notice on this one, see how the ends tab? And we can come around to kind of like all try it out. Because if we have to reposition, it's easier to get the tape and you're not like pulling at it and then accidentally extubating the baby. So we go ahead and tab it down like this and twist, 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 nice and tight. Like even this one, see like how hard you can pull on it and it's not gonna come out. I mean, you don't wanna do that on a real baby, of course, right? Then we have another piece here. I can't get it off. This is why I did it before, because I knew I would have finger issues. Okay. So if you have two people, it's really helpful. One person could be the holder and the other one kind of helps with the taping. The crisscross one you do here, and we bring this up and then start going around, and then you tab off the end as well. And then you kind of use this as a secure mount across the top. So I can bring this bad boy around. This. And then start wrapping, and then wrap one, and then you wrap it around. Oh, sorry.
One part of the mustache, and now the bottom.
Around the tube. With gloves,
like this.
trying to make sure you ventilate them.
So we could use this our
Oh, okay. So you just are really, really, really small baby.
sandwiches. It seems easier just to take.
That's what you meant, where you wrapping the tube.
Yeah, we
Well,
never.
you never have to stop and get you.
Okay, so what do you guys know as a normal tidal volume for an adult? Just nice, easy number.
4 to 6.
4 to 6 mLs per kilo. How many mLs in a normal tidal volume? Just nice, easy number. 500. Yeah? Okay.
Yeah.
So how much volume is in a normal, you want to grab it? In a normal ambu bag?
1,000.
Sorry for the trade name.
12? Oh,
4 to 500.
yeah,
Too much.
The whole thing, how much do you think?
Liter and a half?
15? 50?
I don't know about yours, but ours are 2 liters. So kind of, and you can kind of see the size of the dish. So, so in the pediatric world then, think about, okay, nice 500 for you and I. If you don't have a pediatric ambu bag, like think about how much smaller we're talking for a cute kid.
She's mine.
So, and what did you say her tidal volume, it would be?
Like 250.
So when you're squeezing, you know, so considering that that bag would be, what does that make it? Like an eighth of a push of that bag. Again, of course, considering that you're getting chest rise, if that's with an advanced airway, much easier to kind of rely on. But just keep that in mind. You can always go by the pressures. You know, the manometer. Kid airway pressures, adult airway pressure is pretty much the same. If you have what seems to be like a healthy adult, you know that you don't need as much pressure on a manometer, like, you know, 20, 25 is plenty. It's the same with kids. Those numbers don't change for, you know, previously healthy patients. And now you can all stand up. We're playing a game. The sputum bowl. Get it? Which is a real thing in the respiratory world. We're borrowing the title for the day. So you're going to answer questions, and then the questions will lead to the, you know, physical challenge over there in a minute. So you guys are going to look at whatever screen, and at the end of the question, you'll choose to step one way or the other way. So here we go.
What's the money line?
The money line is if you, well, that would kind of maybe not money line, but the winner or non-winner, that was from my previous career. The winner or non-winner will be the first to do the physical challenge of tidal volume bagging.
Do you want to win?
Yeah. So you arrive to a birthing center and the midwife tells you the baby was born 5 minutes ago. I've known this mother throughout her pregnancy and the baby is here a few weeks early, but please help. What's the next question to ask? So step left if you think it's pulse ox, if right if it's, what color is the fluid? Good. Oh. All right, you're the first to move, right? Did they? Yes. So remember the three questions to ask that are helpful. So what color is the fluid? Right? A few minutes ago, okay, well, you know, 5 minutes ago, good answer, but they're not probably going to have a pulse ox if they're, you know, at a birthing center as it is. So that's kind of a little hint there. But so what color is the fluid? So fluid, gestational age, and
Prenatal care.
prenatal care.
I was blank out for a
You get a
second.
bonus there. Oh, Michelle.
Okay, I forgot.
Oh, she put the whole thing back.
I don't know why I was putting it up. Okay, it's left.
Is Michelle giving blow-by oxygen? Yes or no? Blow-by.
It's blow by right here.
So if you answered no, who answered no? Why? The valve. Yeah. Because some of them will have ones that you can kind of overcome the valve. And then how about now? Is she giving blow-by to the baby? Because we said we could do that if they're not into it. There you go. So just pop that off of the back of your bag if you need to, and then throw it back on. Things aren't good. All right. Is there a higher likelihood of needing a smaller ET tube for anaphylaxis?
Yes.
Yes or not? Good. How about near drown?
Maybe.
Definitely yes,
I'm
or
going yes.
more likely yes, or not necessarily?
Oh, yes.
Why do you say yes?
I don't know.
So,
Irritation. Yeah, irritation.
possibly, there's not necessarily anything wrong with their airway, and so I say not necessarily. I would go with the size that you would would have selected, and then if they're, unless you have real obvious signs of trauma or anything. How about Down syndrome?
Yes.
Asthma?
Yes.
Well, not all.
Maybe.
It's kind of an interesting one, not necessarily. Because that's all good, asthma is more once they get to the branching parts of their lungs, but their upper airway should be okay. Congenital heart defects?
Not necessarily.
Not necessarily, but a lot of the kids that have congenital heart defects are going to have other things going on, and so just be aware of that you might have a higher likelihood of doing it, but it's not necessarily. So that's your answer. On a newborn, which hand do you put the pulse ox? Left or right? Pulse ox, right? Right. Okay. Good answer. 38-week baby was born 4 minutes ago. The pulse ox was reading 75%. What are your next steps? Bagging or continue to transition?
Continue to transition.
Good, because we're not too worried for a while. All right. Oh, how much volume is a resuscitation bag? That would be just a second. Yep. All right. So tidal volumes, we're going to practice. We brought the ventilator so we can get the actual digital readout. The tidal volume is right. Who can bag the closest without going over? So did anybody get all of them right? You got quite a few. You got quite a few, right?
I think Mary should go first.
All right, so you two, because you were also both here first, so you two could go over to the ventilator, and you guys are going to select. So you're going to pick. You two. So are you going? Who are you going to bet on? Are you going to? What is your name, Miriam?
Miriam.
Are you going to bet on Miriam or the respiratory therapist? Or the respiratory therapist?
I got Miriam.
All right. So is it fair? Is anybody on this side of the respiratory therapist? No? All right. So losing team has to help us bring our ventilator back into my car to bring it back across the street. So that's
totally it.
but you guys can all
Way
come and see how this will go. So
So what am
we'll
I
have you do
supposed
like
to do?
5 practice breaths, and then
It's gonna tell you the volume.
so we'll say we're gonna have you bag. Yeah, so you're gonna bag. So let's go try to go 500 on this, right? So you can do a practice one and see what your breath is. So that was, yep. There you go. 3, 4. Oh, that's better. And 5. All right. So now game on. She's got 5 breaths without going over. Closest one, Miriam or the RT. When you're ready. All right. Oh, that's really good. 483, 452, 387, 427. 425. All right, not too shabby. 483 was the closest. It's interesting though, what you feel like is very little change makes a big difference. And so when you think about kids, can you just nail it? 450.
You guys are dumb. I'm going for
484. Nice. Oh, 513. All right. So here, this is for all the money. 5 breaths without going over, but closest to. 427. 387. Oh, pressure's on. 442. 495. That's unbeatable. All right. So many people chose Miriam, and thank you for helping us.